Friends, Dr. A.V. Srinivasan, MD, DM, PhD, all in Madras Medical College, DSc, Doctorate in Science, FRCP London and FA-NN. He was the former president of the Indian Academy of Neurology, former director of the Institute of Neurology, Madras Medical College, emeritus professor, Dr. MGR Medical University. He is 73 years young with numerous achievements. In fact, you'd be surprised to see he's just about 1 year elder to me. He has 100 papers published to his credit. There's 40 books, more than 40 books is written for medical profession. More than 10 lifetime achievement awards. Can you believe? More than 10 lifetime achievement awards which he got. More than 20 unique distinctions in his service. The winner of the 2024 this year General Neurology Award from the American Academy of Neurology. First time an Indian got this award from the American Academy of Neurology. Am I correct, sir? First time. Very good. Apart from this, he is a philanthropist, service-minded individual. In fact, he has done a lot of free medical camps to put up at the cyber. Put up at the cyber.
Name is AVS Brain Charity.
AVS Brain Charity. He is doing a lot of service. I know. I was. Know how much of activity he has done. I know, particularly free medical camps, free food used to be for all the patients who come, free medicines also. So he is going to talk to us on neurology update for family practitioners. Small problems which you come across in our practice, you can always ask your doubts. He will be willing to explain. First, he'll give you an introduction about neurology and then talk about the various problems which we come across, like facial palsy and all that stuff. Okay, so over to you, sir. Thank you.
With your permission, though it's written as latest, I thought I'd just touch through the essence in the neurology. Neurology is always very easy, and if you know 1 to 10 neurology, then you know neurology itself. Then you can take from which particular chapter and then finish it. Number 1 represents one brain and one mind. If there is 2 minds, then we call it schizophrenia. Number 2 represents the right brain and then the left brain. Left brain is actually the science of the brain, the heart of the brain is right. In the womb inside the mother, the right drives the left more. After that, we lose that. Once you become a person, then the left starts dictating you over the right. Number 3 represents there are only 3 basic functions of the brain. All the other functions are all software. Number 1 is, we always call it as the cognitive functions of the brain. Cognition is nothing but perception plus thinking. Yeah, sure, thank you. Number 3 represents cognitive functions, that is perception plus thinking. The second is movement, we call it conation. Third is affect, motor expression of emotion. The whole brain functions in this 3 ways with the help of 4 lobes. Thinking frontal lobe, feeling parietal lobe, listening and speaking with the temporal lobe, and seeing the reality of the world and yourself, the occipital lobe. Those 4 lobes have to function only with the 5 special senses. And there are only 6 hardwares in the brain. Whatever way you look at it, the entire brain controls only by 6 hardware. Number 1 is a programmer. We call it as a basal ganglia. Either he programs more or he programs less. If he programs more, then you get A for athetosis, B for balism, C for chorea, D for dystonia, E for essential tremor, F for fibrillations and fasciculations, and all occur in the muscle, so you can take the muscle. That is myoclonus. The second is, if it is going to really not give the enough move to the brain, you get all the slow movements, including perhaps a boy of 10 at that time. And this man had just been abroad, came back, saw me, asked me to open my throat. Which idiot did the tonsillitic surgery? He has left a septic behind that. Let him have any increased temperature. Do it tomorrow, the surgery. He will become a normal child. He saved me because I was in the hospital for 5 days. People gave me all different drugs, morning and evening injections. And this man simply asked me to open my mouth and then immediately gave the diagnosis. And today, what I am today, thanks to the greatest man whom I respect. And the நெத்தியில் அந்த பட்டை அடிச்சு வர்றதை பார்த்தோம்னா லிட்டரலாக சிவபெருமான் வந்து என்னுடைய லைஃப்பை சேவ் பண்ணான்னு தமிழில் சொல்ல போனால் அது மை மதர் மை எவ்ரிபடி வாஸ் தேர். அண்ட் ஈவன் நோ each and every cell of mine is with him. I am grateful for that. The greatest gentleman who had such an excellent. On that day, I went to the oration and I gave a book also. Now, he was alive. Who is the body for making me? Rathanavela Subramaniam. I mean, I thought I should not say that. And he is in the heart of everybody. So, even to name him, I am not. I only call him Chief. He is still the chief in me, in my brain, in my heart. And that's the thing. With that, the next step is the golden, I always call it as the 8 people in the neurology department. One, Professor Ramamurthy. He came from England in 1951 and started the first neurological department. Though there is a contention that the Calcutta people came first, nonetheless it's just semantics in terms of both days and months. Ramamurthy started the first Institute of Neurology in 1951, and Professor K. Jagannathan sir, he just started the neurology in 1957 after returning from the National Hospital Queen Square. And then the top Professor Arjun Das and as well as Professor, this of course is, he is the person who started the neurology department, paid person. And he is the person who joined as assistant professor and a professor, Ramamurthy. This time I think the man who worked in Canada returned back, Professor Zahiram at Summit. He will teach you how to write it. With all apology for the words that he used to. He said, old people, urination, language, you just correct it. He will correct it so perfectly and precision and power and voice, and as well as make the people to write in a beautiful way. He is a great professor. This man is a really Professor K. Srinivasan. He has everything in his mind, but still he will carry the books. And he will teach us where to look for, to whom you actually can take a guide. He is, of course, as an MBBS student, I was with him. In MD, I did under him. DM Neurology, I finished under him, and I became an assistant professor under him, and became the professor. And Professor K. Srinivasan, the genius, the first person who worked in, of course, in the US and came back and worked in Madurai itself and did not come. The first pediatric neurologist of the country, Professor G. Kumaresan. And these people form the teachers. He is my teacher of teachers, Professor Velmurugendra. He is my real heart. He made me what I am today. And he really made me to do the PhD. Both of us joined together and gave an international AVS CUV criterion. That was my PhD thesis, for which he was my boss. And he was the person who really encouraged at every step and also made me a professor in charge, though I was only an assistant professor. With that small introduction in the... Sorry?
Arjun Das, the top of the...
Top is Arjun Das. He joined as a first person to join Professor Ramamurthy in 1951 as a medical person looking after till Professor K. Jagannathan returned from England. He was an honorary professor. Professor Zahir, Professor Krishnamurthy Srinivasan and Professor Arjun Das, all of them are all honoraries. But they stayed there from 9 o'clock to 5 o'clock in the hospital. And very rarely, they never leave at 12 o'clock. And now, this I thought I should spend 5 minutes to all my teachers who have taught me where I am today. Number one is Professor, of course, V. Balasubramaniam. We used to call him as Encyclopedia of Anatomy. He can take the class without reading the any page. He can just talk on our subject. And Professor P. Narendran sir. He brought the CT scan to India in 1980 when Hounsfield invented it in 1974. The first especially the state, the country to get the CT brain. Thanks to Professor P. Narendran. I would say Professor S. Kalyanaraman is called the father of the CME program. He started the first especially CME program in this country in both neurology and neurosurgery. Professor J. Reginald, we just missed him recently. He was my physiology tutor and he really made me interested in neurology, but he went to neurosurgery. And then Professor Pam Brunensen and Professor Mohan Sampath Kumar, I always, I'm very fond of him because when he was the head of the department, I was professor of neurology. We really mixed very well. And these four people really form my four brains. And we all work together in our setup. And for anything and everything, Professor Kanaka Madam in surgery. And she is the first lady neurosurgeon of the country and in abroad. And totally dedicated to only poor people. She lived almost in the Institute of Neurology and worked only for the poor people. We can never ever see such personality. Only for the whole world for service. And Madam is superb. And one day when I came late, when I come late, AV, you never come late to the morning meeting, which starts at 7:30. So we all to be present at 7:30. Of course, above my parents who made me everything, dedicated to my family for making everything worthwhile. I touched the moonstone in America when I went to US on the deputation, and then my wife and my son and my mother-in-law, above my father. These people made me what I am today. And of course, it's the new department which came. I have just finished all your the 10 steps in neurology and the special senses which come because of the introduction. And I wanted to just say these are the most important point in the spinal cord. A practitioner should only know what to look for. If I look at it as a spinal cord, you have spasticity, you have weakness, you have fasciculations, you have bladder and bowel involvement and trophic changes. So you make 1, 2, 3, 4, 5 in your practice, put it plus or minus. Anterior nerve root is belonging to the segments weakness and segmental wasting. Posterior root produces pain, paresthesia and numbness, and of course the deep tendon reflexes. A very simple examination. I want people to do it in the easy to do it, very easy to remember. And I would like to tell you it's easy one to do that because when you see a patient as a practitioner, you can be confident in this. So let's start with the upper limb motor system. A person who cannot bend and that is C1 to C4. C5 is abduction of the shoulder. This does not, all the muscles are involved. We are just picking up the easy way of examining the patient, which will hardly take 5 to 10 minutes for you to finish the neurological, motor, sensory and reflex levels. Abduction of the shoulder is weak. Flexion of the arm C6 is weak. Flexion, extension of the arm is C7 is weak. Gripping C8 and T1 weak. So once you do this test and then make up mind, it's enough. Because in life, as a doctor, you need only 6 senses. If you have the 6 senses, you really make your life extremely pleasant. Number 1 is an observation sense. Once you observe a clinical sign or a symptom, please make a note of it and then start recording it. The real missing link between the west and the east is that recording. We all try to think that we'll get it best in the memory, but memory, pity and beauty are always short-lived in life. But if you do that and then record it, and then once you get the recording sense, God has given us definitely a common sense. So when you have the A, observation sense, 2, recording sense, 3, God-given common sense, you get the clinical sense very easily. Once you get the clinical sense, the therapeutic sense automatically follows. But one swallow does not make a summer. So you have to prove by statistical data analysis and use by predominantly a statistical method to prove your point, then that's the 6th sense. So 6 senses, once you get the 6 senses, 7th sense of happiness automatically come. Please remember, especially with regard to statistics Statistics is the paralysis of your analysis. If you do too much of statistics, you will result in wrong answer. A single observational study in the whole world has turned the world upside down and has brought a new clinical finding. With this small introduction, of course, all these findings which have been 8, I always say 8 languages. Very simple. Ask him to repeat a sentence, 7-worded sentence. If he is not able to repeat it, there are only Broca's aphasia, Wernicke's aphasia, global and conduction. If he is able to repeat 4 but still has a speech problem, instead of Broca, it is transcortical motor. Instead of sensory, transcortical sensory. Instead of global, anomic. And then conduction becomes alexia. So this is a very easy way of remembering. The 9 etiology and then the system which you all mentioned it. The commonest, now that I have given a general introduction of 1 to 10 neurology, and then the second step that I have taken through the different neurology, I think the commonest cause we will take today is headache. Headache is a headache for all of us, and it's very difficult to treat. And as it is, Americans, more than 30 lakhs people, it's 20% women and 7% only men. The statistical data, you have to swallow it, but it's a fact. So who is causing what, we can decide. Most of us have some migraine manifestations early. And then when you look at the recognition of migraine, it is a pounding unilateral preceded by either visual or error. I always look at it in a patient with a headache, whether the patient has got visual aura, whether he has got tinnitus, whether he has got perioral numbness, whether he has got difficulty in swallowing or nasal regurgitation, has he got a weakness, sensory deficit, or difficulty in walking. Light and sound sensitivity almost picks up the lesion migraine.
Without aura, you can never have migraine.
Without aura, you can get migraine. That we call it as a common migraine. I mean, you can this is not a pure lecture, so you can just interfere with me and ask me questions. That will be good. That's called common migraine. When it comes during the cycle, then we call it as a catamenial migraine. When it comes with unilateral, it is called hemiplegic migraine. It runs in families. One practice point is, these patients, when they have unilateral deficit, please do not use sumatriptan or any triptans because it's likely to cause heart attacks. That's a practice point. So, of course, I'm not going to discuss about the migraine because it's predominantly not interested in this. But remember, what are the worrisome headache? We call it as a red flags. If you have a red flag with a headache, definitely think of some other neurological deficit. The red flag, I give a mnemonic as Snoop. S is systemic symptoms like fever and weight loss, or it can be a secondary risk factors like HIV or systemic cancer. N is a neurological symptoms or abnormal signs, especially confusion, impaired alertness, and or consciousness. Then the third, onset is sudden, abrupt, and then most important is split second. And older, new onset and progressive headache, especially in people, and the previous headache history, first headache or different changes in the frequency. So if a person comes, I have been having this headache so long, suddenly the character has changed, intensity is changed, severity is changed, the neurological deficits are coming along with the headache, mark out. You have to look for, it's a lead sign, so you have to investigate. The reason why we say is, the Americans are paid more to do more. The Britishers are paid more to do less. Trained in England myself. In the National Hospital, Queen's Square, we have the greatest by the government to send it. And then they strongly believe, because the incidence of what you get positive results by CT scan. If you use one CT scan, you are using 100 X-rays in him. Remember this. Even the fastest CT scan comes to 50 X-rays. That means you are going to touch the genetic loop in the particular person. Watch out when you are writing the CT scan. What about the MRI scan? MRI scan is usually no harm, but the results are going to be released in another 2 to 3 years. It has an effect on interiorly the enzyme system. Though we say magnetic is unlikely to be hitting on the individual cells, but it may touch on that. So this worrisome headache, you should remember, is red flag. And these are all certain findings.
Migraine is
Menstrual cycle, yeah, it can come before the cycle, during the cycle, or after the cycle. So it can last for about 3 to 10 days prior to that. So anti-epileptic drugs have been found to be very useful in short courses of 10 days. So you can use them. So that's why it's called catamenial migraine and catamenial epilepsy. Both of them, they go back to practice. Just before that or during the menses or later. It is presumed that the hormonal change during the menses has an effect on the astrocyte, because the latest thinking in the brain, people always thought why a neuron should become an epileptic neuron. Then they found the astrocyte physiologically from the asynchronous to synchronous develop. Once it becomes asynchronous to synchronous, they develop epilepsy and make the neuron neurotic. Epileptic. So this is an example that has been brought now recently. Of course, these are all the signs that you must remember. The phases of migraine, I leave it for you to just remember. One thing, I always call it as a practice point. There is a psychic changing and a craving for chocolates if it begins. Watch out in private practice. He is the person is a classical of a migraine. Especially the fellow who is not taking the chocolates, just start eating the chocolates. And the aura, of course, we have just had it. But remember this, the triggering mechanism is very, very important in migraine. It's always felt that the migraine is really produced by any cold things like chocolate, cake, treat, etc. And recently, prawns and crabs are notorious to produce migraine. The reason, these cells are now brought in with chemicals added. Sea prawns, nothing will do. It will have no problem. But nobody gives the sea prawns in the water. It's a cultured prawns. Watch out for the cultured prawns. Now, the most important thing is don't ever. At least you must take 8 to 10 tumblers of water. Next, 6 hours for a scholar, 7 hours for a traveler, 8 hours for a Thirupurkeke. The duration of the sleep. If you miss it, you have a migraine. Why I insisted on the 11 to 5 is between 12 and 4, you get the real neurotransmitters released in the brain for us to work better in the next day. So you must leave between 12 and 4. Most of our prime ministers also take that between 12 and 4 only they work, and they can work with full efficiency. See, this is the reason why, if at all you work with, you don't have to pick. Then the question arises, what about the people who do the night duties? When he does the night duty, just like we come and then eat our night food and go to sleep, the night duty people should come in the morning, have the food and go to bed for 6 hours. They should never ever get and work during the day. Then they are healthy and wealthy and all. Now, with that, the migraine phenomenon, lot of people have described lot of changes. But one thing remember, it can be even a focal onset symptoms which can mimic as if it's an epilepsy. And visual phenomenon can take it as a TIA. What is the main subtle distinction between this and that? This one lasts for hours, whereas TIA usually lasts for only about 4 hours. But for technical diagnostic purposes, they go up to 24 hours. They say TIA, 72 hours for the reversible ischemic neurological deficit, and above that is a stroke. And nausea, vomiting, everybody knows, bilateral pain and etc. The light and sound sensitivity varies from the different cultures. In India, the sound is not light. The light and proportion is very less. And some dicta. These are all the dictas that the private practice person must know. Number 1, paroxysmal extent is likely to be migraine unless proved otherwise. Paroxysmal, coming and going. Second, sinuses headaches are like tension headaches. 3, most important, first ever severe headache, sudden thunderclap headache, remember and explore subarachnoid bleed. These are the 3 basic clues in the practice when you are seeing the patient for the first time. Then, this is I always call it the migraine checklist: coffee, People should not get too much into coffees. Two reasons. Number one, caffeine contains as really produces in some people a tachycardia. Second, it can kill the appetite. And three, it can also precipitate a migraine. In some people, if you take too much of a cell, but if you take only one or two something, coffee, especially in the morning, really tickles it. Sleep, depression, we have talked about it. A recent concept in the depression, anxiety, and stress. Hitherto, people believe that serotonin is secreted in the brain. Now we all know that it is not secreted in the brain, it is secreted only in the stomach. And hence, anybody who has got a stomach problems like diarrhea, irritable bowel syndrome, or as a matter of fact, any other gastrointestinal disorders, they are likely to have the serotonin not secreted properly, and the people become sad. Sad, yes, is for stress. They are very easily stress-prone people. A, anxiety always operate in them, and the D is depressive feelings. They start getting it. So remember these three problems, especially serotonin. In the stress and then the menstrual period also. If they are going to have a longer headache, then it is likely to be migraine. Acute attack, of course, when you start treatment, it comes into the triptans, NSAIDs, Floricet, migraine, etc. All those things are all practical points. You can get it.
Sibelium is not there in this.
No, Sibelium is a drug which people now have a second thing. It produces obesity syndrome. Second, if you continue to use Sibelium, you are a potential person to develop Parkinson's disease. Not the causative factor, but the precipitating factor. If people who take flunarizine and Sibelium, if they take it for a longer time without your knowledge, then they are likely to develop early Parkinson. Not that it causes it, but it always precipitates it.
Triptan is the best drug for
Triptan is the best drug provided it is not one. I told you the hemiplegic. Second, when they get the pain and what we call it as allodynia. If anybody gets allodynia in the head and migraine, do not use triptans because they are the people who get the heart attacks. And now, sorry.
Application of naproxen with the domperidone. That is also available.
No, naproxen with domperidone, once again, watch it with discretion and as well as use it for a short time rather than for a long time. Even domperidone is a notorious drug for us to get the Parkinson. If not Parkinson, at least it slows down. If not that, then it produces increased rigidity. So, whenever migraine established patient comes, please don't use this in long term. But for a short time, it's an excellent drug. It can
what
be
is
used.
the NSAID, best NSAID for
Naproxen. Naproxen, the world, of course, is a very good. But only thing is NSAID, if you prescribe, please do PR interval and QT interval prolongation, including SSRI. If there is a prolongation of this two, you are a potential person. That person is likely to get the heart attacks. So these are all mandatory requirement in most of the US or Western countries. Now we don't do it, we just allow them to do it. So,
What about beta blocker?
Doctor, once again, create a lovely drug, still the best drug. But in India, incidence of allergy and as well as COPD is very high. And then, once again, tachybrady arrhythmias in India is very high. If he develops a bradyarrhythmia after one single dose, do not use propranolol. So these are the limitations. Doesn't mean that it is very useful in patient because it is still the best drug. Above all, the amitriptyline hydrochloride. Whatever the American says, the British people don't agree. Whatever the British people agree, they don't agree. But in terms of the management of migraine, some of them definitely prefer, as you rightly pointed out, this drug combination. But watch out only for these two essential cardiac because it's a practicing point.
So tryptophan, amitriptyline.
Yeah, it's very good. Amitriptyline. I told you, PR interval and QT interval, please do it and then do it. Short. Because when you take the headache and pain, wherever it is, it takes 3 weeks for it to remove the pain of headache. Whereas the initial improvement in the headache pain is not due to the headache pain relief, it is due to the depression which is accompanying it that gives them the betterness. So, but the actual fact of amitriptyline is still one of the best drugs provided PT interval. Please do, whenever you put the patient on amitriptyline, PR interval and QT interval, if it is normal, you can pump it with amitriptyline, you will get an excellent results.
How about ultraset and all those drugs?
Ultraset, everything for increased pain, you do it. See, there is a central sensitization phenomenon occurring in most of the pain. Unless we don't get the central sense down with them, otherwise using it is good. If you get a person coming with pain after 6 months, give it to your best friend. You'll have a tough time in treating it. That is the easy way of escaping off. Otherwise, within 6 months, before the central sensitization, ideal drug. Madam knows the physiology very well. Central sensitization phenomenon is the beginning story of a weakened, or I can call it as the efficacy really goes down. And when is prophylaxis is needed? This is a point of contention in most of us. The whole world is interested in prophylaxis. How long to give, how much to give. When you look at it, I think more than 2 per week, please put them on. First, the world said 4 attacks in 2 weeks. Now they say 2 attacks. And the attack duration, if it lasts more than 48 hours. These are all the guidelines. Doesn't mean that it is absolute. I mean, it is not absolute. Not absolute. The different concept. Then the headache severity is extreme. Unacceptable adverse factors, especially occurring within the acute migraine treatment. Instead of calling it as a complication of the treatment that we give, tell them that if it is going to be there, it is a very serious migraine, it needs to be investigated. Don't accept that because of this drug it has produced this complication. Then, migraine substantially interferes with the patient's daily work. And special circumstances like hemiplegic migraine, I already told you, with a permanent neurological deficit can come. Please do not use triptans in them. And of course, these are all varying dose. The practicing angle, I put it, the dose can be from 40 milligram to 320 in the best. Not in our east. 320, we can't stand. You just go into bradycardia. The calcium channel blocker, please work out. It's actually 10 and 20. Verapamil, some people believe strongly 120 to 180, 480. Once again, I don't touch 480. And the TCA, tricyclic antidepressant, I told you 10 and 20. So please start amitriptyline, start low, go slow, you are always successful. And the SSRI fluoxetine is 20 to 60, I prefer 20 to 40. These are all highly individualized. So there is no such thing as a buyback. You can take this. And the preventive therapy for migraine, anticonvulsants have been used. But remember, anticonvulsant dose is less. Whereas the really therapy course for headache, especially epilepsy, has got a greater milligrams per person. And antihistaminic cyproheptadine is one of the very famous. When I was doing my DM neurology in 1980, cyproheptadine played a very, very important role. And slowly but not surely, we always remember what is science of medicine today becomes history of medicine tomorrow. And hence, you have to be very, very, not be very, very hot step on one step and then start doing it the same thing after 2 years.
That's what it is, appetizer, no?
No, it's an appetizer. It used to be even for patients with headache and migraine. And role of the gold standard in migraine, because we have already finished it. And a word about headaches in women are more commonly than men, and 18% and 6%. Some people believe 20% and 7%. Estrogen plays a very crucial role in the key factor of the increased prevalence of migraine with women. Estrogen is not coming. But one thing, headache alone is the one. But really, if you look at it, estrogen protects females from getting almost the entire stroke 1:6, heart attack 1:4. So they are always privileged and the nature sees to it that they are alive. And second, when a person lives up to 65 years and then after that how many years he lives, when they did a statistical analysis of the entire world, 17 hours for a male and 22 hours for a female. You can just imagine how the nature protects only females and not males, and they are given a longer duration. And this is if people have not read that, I think you should read the Selfish Gene book. It's beautiful. But very easy for private practice. Incidentally, I'm just going away from that. Very easy to say how many sugar you have to think of it is. All world has accepted for 100 as a fast. So fasting sugar should be 100. 2. Then what is the PP sugar is your age. So if I am 75, my PP sugar should be 175, finished, period. So the age plus 100 is your PP level. And the other way around is, if you are 50 years, 5 HbA1c. If you are 60 years, 6. If you are 70 years, 7. After that, you remain in 7. So these are all very easy. The same thing with regard to your weight. Height in inches is equal to weight in kg. That's a practicing point. 10 plus 10 kg for a male plus 5 for a lady. And the abdominal circumference at the level of the umbilicus is, if you take it, if it's half of your height is your abdominal circumference. If it is more than that, then you get into central obesity syndrome, which can cause stroke or any type of thrombosis, etc. And effect of estrogen, for the sake of the females, I just want to say, fluctuations in estrogen can cause changes in the prostaglandins and the uterus. Prolactin release can occur and mimic as if it is going to be something like a tumor in the pituitary area. They can get a milky secretion, it is going to be at a higher level, and then melatonin secretion is definitely disturbed and produce insomnia in such patients with the changes in the neurotransmitters, especially catecholamines, noradrenaline, serotonin, dopamine, and endorphin. Now, of all the neurotransmitters, I always believe in 3 neurotransmitters. Number 1, dopamine, which produces basal ganglia. Number 2, acetylcholine, which produces Alzheimer's dementia. Number 3, noradrenaline and adrenaline produces either mania or depression, or all of them are independent but interdependent. If a person gets a dopamine this beginning, then you get immediately the memory disturbance, you get a behavior problem. And a person gets a behavioral problem, also develops Parkinson's symptoms and then memory disturbance. If a person gets an acetylcholine loss and then gets a dementia, he also develops Parkinson's symptoms. And so of all the neurotransmitters in our life, all these 3 are secreted between 12 and 4. So watch out, don't sacrifice your midnight, especially between 11 and 5. If you sleep, everything can get delayed. Now, lifetime prevalence of headaches in women and men, if you look at it, any headache is 99% and men is once again low, 90. Migraine is 25% and 8% in men. Tension headache is 88% in female and 69%. And the exact reason for that people are not yet given, but probably one over the other or the other over the one. The important headache issues to be covered are menstrual migraine, menopause, we already mentioned it, oral contraceptive and use of migraine. Be watchful over especially the oral contraceptives. If you use it, you are a potential person to get a migraine. 2, transient ischemic attacks, if it is associated with, I always call it, if you look at your once again 5, A, B, C, D, E. A stands for, of course, acidity, arthritis, and as well as most important is especially in the stomach. So the B stands for blood pressure, C stands for coronary artery disease and as well as cancer and stroke, and D stands for diabetes mellitus, E stands for elevated cholesterol, F stands for fits and as well as for fatigue, and G stands for giddiness, and H stands for headache and as well as for the hypothyroid state. I stands for injury to the brain and as well as injury to the neck and to the spinal cord. If you are free from A to I, then you are a J jolly person with a problem. But if you are an ABCD person, A for alcohol, B for beeda, jarda, C for cigarette, D for disco, dance, games and drugs, you are likely to get any one of the neurological problems that we have mentioned already. Tamil சொல்லப்போனா டெஃபினட்டா குடியின் விலை உடலுக்கு மாலை, புகை உயிருக்கு உலை. That's all. Now, and I'm just skipping the headache. We have spent quite a good time, more than that, and we can just leave it at that. This is answer. Vertigo is a very difficult topic in practice. So I have taken the topics which are very tough for a physician. Vertigo, and once again I always say, if a person comes to my clinic and then says I got vertigo, I ask this following questions. தலை சுத்துதுங்களா? ஆமாம். உதடு சுற்றி மரத்து போயிருக்குதா? ரெட்டை பார்வை தெரியுதா? காதில் சத்தம் இருக்கா? ஸ்மெல் அண்ட் டெஸ்ட் நார்மலாக இருக்கா? ஒரு டைம் ஒரு கால் மரத்து போகுதா? ஒரு டைம் ஒரு கால் நடுக்கம் வருதா? நடந்தாட்டம் வருதா? If you have no double vision, if you have no nasal problem, if you have no tinnitus, if you don't have nasal regurgitation, no incidence of weakness, sensory deficit, or incoordination of the walking, unless proved otherwise, it is peripheral then central. So you can be 100%. Ask him whether the particular side, when you go to turn it, he gets a giddiness, then it's 100% benign positional paroxysmal vertigo. Vertigo is a very difficult subject, but our clinical approach, I'm just giving it an illusory symptom of rotation. If there is, we can call it a person when he comes. When he lies down, whether the headache disappears, then periphery and center. Except ruling is alcohol and head injuries. In all the other central causes, of course, you can see immediately it's immaterial whether he lies down or remaining hand. Whereas periphery is easy. And balance, imbalance. 5% of the patients is the prevalence of the vertigo and giddiness. If it is a hospital statistics, you get into type 2 statistical error because of the frequency being different, the number of patients you have studied less. When you look at it from a general angle, so in India what we lack is both incidence and prevalence. And most of the disorders is because we are lacking, 3M and 3M is very, very useful. And the first 3M is megalomaniac man's attitude. I know everything finished. So he doesn't, you get into the epidemiology. The second is, of course, manpower, money power and motivation. Everybody has manpower, everybody has motivation. But the money power is little bit lacking in most of the interesting cases of research. And 10% of the patients visiting the otorhinolaryngologist, what is causing their vertigo? If you look at it, it is, I've already told you, from the vestibular system, the visual system and the proprioceptive system. To put it in simple terms, the eye, the ear and then the neck, especially the proprioceptive input, decides, because they should go properly to the brain. And if there is going to be a delay in any one of these three structures and if it doesn't reach the brain, you will get vertigo. And a lot of things people have said. One word about Meniere's disease. In our class teaching, when there is a Meniere's disease, unless proved otherwise, it is tuberculosis. Now we know Meniere's disease is not due to tuberculosis alone, it can be due to any other factor. Labyrinthitis is very good and paroxysmal vertigo because of the position. But remember, the clinical point in private practice, if a person gets a headache or vertigo associated with headache or combination, think of balance problem in the middle ear, send him for a good ENT workup. Suppose a person has every time headache, then the hearing deficit increases. It is a 100% a proven point for Meniere's disease. It's a classical. Then give it to your best ENT friend. It's easy to treat him. And then cause of vertigo, vestibular acoustic, we mentioned it, arteriosclerosis and cervical, vertebrobasilar insufficiency, and as well as the brain tumors. Non-vestibular causes. This is a practice point for all the practitioners. If you look at the non-vestibular causes, other than that, it can occur due to ocular vertigo, or it can be occurring in a plain anemia can produce vertigo. Third, cardiovascular, especially orthostatic hypotension, falling below 20. There are not 100%, but we have considered as 20 and plus. That is the plus 10. And if a drop of 10 in diastole and 20 in systole, we can call that as a possible orthostatic hypotension. The cerebrovascular disorders, psychogenic, very, very, very common in headache and giddiness. If a person has any one of the following three in practice, in our daily practice: A, chest pain; B, abdominal pain; C, giddiness; and D, leg pain. Unless proved otherwise, it has got a basic psychological factor. Because if you have ruled out the general causes of neurology and as well as vascular, think of the possible psychogenic, because pain is a hardly built emotion. It cannot be scientifically measured, because all the factors which are operating on the emotion can never be scientifically measured. Instead of that, you start using the scale. The scale depends on your mind. If my mind is good, I'll give a score of 7. If my mind is very poor, I'll give very poor, means 4. If my mind is very poor, I'll give a score of 7 and 10. So score is very useful. So now we say you have to take 3 times the score of pain score scale and take the average, and that is the real starting point with the research. So all emotions are beyond, but when you look at it from a human existence, of all the functions, the first function of us is awareness. I am aware of whatever is happening. Awareness is beyond science. Second, awareness then to intellect. Intellect also cannot be measured by science. Intellect to mind is probably 50% is science addictive. Reason, mind has got, we always call it divided into 2 for private practice purpose. The mind, when you take it, it is actually spatial sequence and temporal sequence. We cannot know where our thought brings from, atmosphere or from our brain. It is still debatable. Once you cross the mind into the brain immediately is all amenable for all our scientific experiment. Mind acts on the body on the environment. Now, why I say that is, vertigo, you should be very careful in establishing your deficit, because you will miss the bus when you are really looking at it. So one must be very important. Hypoglycemia is notorious to have epilepsy, multiple sclerosis, head injuries and migraine. I think subjected to your approval, we can take it to a question level, or you want it to be purely discussion. I think question answers double will be very good. I'm going to just touch on all the other, these are all the test is relevant. So we have already really seen it. I always say,
I want to know what is the drug to give for migraine now. Now I got confused. Till now I have given Cybelium, but now Cybelium is not good. What drug to give?
No, I never said Cybelium is not good.
Not that
Cybelium is good. Use it for short, but don't use it for long.
We give it for
Short means at least from 3 weeks to 6 weeks. Then prophylaxisally you pour it with that amitriptyline and as well as with the other drugs that we can use. The ideal drug for acute and then chronic. Now people are saying there are 2 things. One, we have got a stimulation. We used to do Botox for migraine, but you have to put 30 pimple spots in your scalp. It's not worth it. Then the second thing is, of course, if really the ideal drug of choice, people used to say, you have to use only prophylaxis. And acute phase, you can use anti-epileptic drugs, of which one of the most important thing is, especially I can call it a sodium valproate is very good. Sodium valproate acts on the mind, sodium valproate acts on the neurons. It can be used for any depressive elements, so short dose can be given, but not to be given in childbearing age group or women. In men, I think it is a very good drug. But if they have attained menopause, then they post headache. We used to have a common practicing point that once they get menopause, they get rid of their headache. No. The whole goal of migraine is treat the attack and prevent the disorder. The preventing the disorder is, I always call it as a chronic migraine, which is 15 attacks per month in a month, very difficult to treat. Those patients now, the recent drugs are coming to existence. Never be the first man to use it, nor be the last man to try it. That's a golden rule. So I still believe for prophylaxis, amitriptyline is still good drug, provided PR interval and QT is normal. Then next, if there is in my practice, if it is very going to be severe and then he comes into me, if it is more than definitely 2 days, that means it is a 100% status migraine. That patient requires a steroid. provided the patient is not having a strong diabetic. A, B, especially with regard to the potassium. So you must be careful in such way.
So what we do is we give only Vertin for every person.
Once again, Vertin, the person who used it have used it for 3 years and nothing has happened. And it doesn't do any harm. But if you
It's not
use
very
it,
good effect.
huh?
It's not good effect. Because
100% it has a very good effect in the beginning. But the main point is we used to have a lower dose. Never use 16 milligram. Use 48 milligram boldly in there. And then use it for 3 weeks to get an excellent result. Inadequacy, intermittent and low dose produces more problems than difficult. So we give a full dose for it.
48 OD.
Yeah.
Doesn't produce sleep disturbance.
It's,
48 milligrams.
it doesn't produce any sleep disturbance, which it does in some people. It doesn't produce any excessive sleep. In which case you can use melatonin group. 3 milligrams or 5 milligrams depending on his weight. I use 3 milligrams less than 70.
But did you also allow
I used to take.
Have
Yes.
you
Sorry?
started using ganoxolone for seizures? It's a neuroactive steroid.
Yeah. But I'm just telling them, don't be the first person to use it, nor be the last person to try it. So you wait for the literature has not yet come in the
Recently approved by FDA.
FDA approval says there are 2 ways of FDA approval. Number 1, it takes a long time and then get approved. Number 2, you can get it by short-term method. Those who have worked in US can know that. If it is not causing any problems, side effects, then you can use the drug, provided that 10,000 patient years must be taken into consideration before you consider it as normal. See, SSRI, SNRI got into problems because of that. Then they started seeing the heart attacks more. Now people are saying that gabapentin and pregabalin has used like water in our cells. But reason 2 or 3 very important people have just suggested that the people who had a cardiac problem, if they take it, they get into complications. And hence watch out for it and a complication.
The fruit fig is used to.
Huh?
Peripheral neuritis. They are given.
Yeah. The peripheral neuropathy is, 1 minute, sorry. Peripheral neuropathy has got 4 symptoms. Main thing. Number 1, it produces pain. Number 2, it produces weakness. Number 3, it produces definitely wasting of the muscle. Number 4, numbness. In that order, 75 to 100% relief for pain, 75 to 50% relief for weakness, 50 to 25% for wasting, and 25% is only for the numbness. So tell them very hand when they come and then tell you. The most important, I always call it peripheral neuropathy, 3L method. 3L method, the L1 is listen to the patient, he gives you where the lesion is. Then look out for the physical finding and locate the anatomy of the lesion. This is a practicing point in our daily life. So listen to the patient. If the pain is of a real severe pain, because 10% of the pain fibers are affected alone, it produces an itch. Itch is also a painful sensation. Please mark. 10% of the pain affected, it produces itch. 30% then it becomes lancinating painful. Depending on which condition, suppose labor, once again, labor pain, you assume it as 100%, and kidney pain, that's 80%. So when you treat a painful neuropathy, which is only 10%, and 90% of them are invariably bilateral, symmetrical, sensory, motor weakness, rather than a painful one. So when I get a painful neuropathy, once again, that is where the central sensitization phenomenon is very, very heavy. Even if you touch it, you get the pain. So be careful. So painful neuropathy after 6 months is difficult. Before that you can use. The value of the, especially the B12, all the other things. Now people are saying that if it has the combination of the peripheral neuropathy pain associated with especially low B12 and D3, they are the people who have a very severe pain in practice. Otherwise, I think you need to do it.
What about using duloxetine, carbapenem, and pregabalin?
Now the question is the world over, the double-blind trial, classical trial. Previously, pregabalin, the reason was we used amitriptyline, which takes 3 weeks for the painful relief. Then gabapentin came, which gives relief in 7 days. Then came the pregabalin, which gives relief within 3 days. So everybody said pregabalin is the drug of choice of neuropathy. Then they found that it is not, because it produces more giddiness. In America, they started off with 25 milligram to start with. In India, they straight away got the 75 straight, and they got a bad name by having a giddiness, next day walking difficulty. Then they mixed pregabalin with, as you said, rightly, the duloxetine. They found that it is now very useful. I use it in a people with peripheral neuropathy, duloxetine, but only thing is, if the patient is addicted to giddiness especially, please don't use it. Other than that, I think it is good. It's a combination, works very well in practice.
Along with methyl.
Aligned with methyl, you must be very careful, because if it crosses 2000 above, then in that case, that itself can cause a problem. Permissible up to the 2000. Beyond that, I think we should remove the methylobalamin, because it does has a direct action on the indirect methods. So I personally favor short term. If you use drugs, you get a placebo effect, which gives you a very good name in the beginning, and is removed immediately after 3 weeks to 6 weeks.
What is the role of Sugiron and Stevitil in vertigo?
Vertigo, once again, Sugiron and Stevitil is very good in the beginning. I always call it as a 3-5-7. You can use it in the 3-5-7 steps. But the main point is, don't make them use for a very long time. They are the people who get the Parkinson's very early. Because people don't come and then ask you, they get the same prescription from the. A lot of people have got this problem. Acute phase, 3 weeks to 6 weeks is ideal. Beyond that, watch out.
But beta-histine can be used for long periods.
I told you, it is very safe. People have used it for 3 years. And they are very happy with that drug because it doesn't produce any side effect. I always tell them, if you ask for any patient saying, sir, is there a side effect? Side effect na adhigama irukku, don't worry. So those drugs can be easily mentioned.
What dose?
Those
48
No, I told you 48 in the acute phase, and then when it is going to come in that, it will come down to 16. Acute phase, don't use 16. You don't get a good relief.
So 8 and all is gone now.
Not gone.
Vertin 8 only is being prescribed.
Vertin 8 people are prescribing it, and it is good for good for 2 people. When you use see, we have a tendency to use inadequate intermittent low doses. Most of our practices.
To be on the safe side.
To be on the safest side of not having any relief also.
Maybe it's about
Parkinson's
disease.
Huh? Parkinson's disease. See, Parkinson's disease is once again a very common denominating factor. I told you there are 6 systems. When I get the Parkinson, we are trapped in practice point. T is tremor, R is rigidity, A is akinesia, and as well as P is postural response. Patients are trapped into trap. If they have got only one, then we call it as a possible PD. If they get 2, then it is probable PD. When they get 4, then it becomes a clinically definite PD. But if you want to make them diagnostically, a person comes with a mild tremor. You want to prove whether it is an essential tremor which runs in families, or is it a beginning of the Parkinson tremor, then use immediately the test is you can take by means of very good examination. Arch typically, if you take the essential tremor is anteroposteriorly, whereas Parkinson is big. Throw that, of course, best is fine to say if you're going to come to you, Trodad scan is the best one. Ask him to do a Troda scan. If it is positive, then it can divide into two. One, it can go. But remember, the golden rule in neurology are three. Number one, absence of the evidence is not the evidence for its absence. Two, statistics is the paralysis of your analysis. Three, never be positivity indicates a problem, negativity does not precludes it. But if the investigation is done and it gives you the result, then it's fine. If it does not give you the result, be confident that it may come later. So, but at the same time, Trodax scan, it gives me confidence to say that this patient has Parkinson and no, definitely familial trauma. If a father, mother, grandfather, everybody has, can it still be Parkinson? Yes. Reason. If you have 100 patients with familial trauma, 10% of them, they do develop Parkinson tremor after about 20 to 30 years, because essential tremor has got two, early appearance and late appearance. The late appearance only causes the problem. So they confuse with the Parkinson disease. 90% of them, they go through the lifespan brilliantly. The reason is people who have got familial tremor are extraordinarily talented people. The contrary is not true.
How do you find Alzheimer's?
No, the Alzheimer's, suppose if you remember the brain, if you take it, the frontal, parietal, temporal and occipital. If you get the parietal and then the temporal lobe is involved, you get Parkinson's disease, Alzheimer's disease. If you get the frontal involved, you get frontotemporal. If you get posteriorly, you get definitely basilar disease. The clinical point is the memory disturbance if it starts. In private practice, after the age of 60, you get age-associated memory impairment which is permissible according to your age after 60 for the places, person, names and phones, numbers and including the names of the people who are very close. Drug also. But the main point is, suppose the person takes the morning tiffin and then says you have not given the tiffin, you must give the tiffin, that is the beginning. If they don't dress properly in the house, probably. Third, if they go to the house, if they can't return and ask for how to go to my house. These are all the early signs of the Alzheimer's. Or they go to the office and then they don't take the change back every time. Occasionally you can come back without taking the change. But if you go to other places, then you have to be careful. So these are all the four, what I call it as a four important points for us to think of a possible Alzheimer's disease. Memory is more affected. For one differential diagnosis, if that memory is associated with the difficulty in walking, he has incoordination of the walking and he has got incontinence of the urine. He may not suffer from Alzheimer's, but he may suffer from the normal pressure hydrocephalus. So when I see a patient with difficulty in walking and incontinence of urine and then memory disturbance, he is a very good candidate for normal pressure hydrocephalus for a surgical intervention. But if the memory system comes first and then the incoordination and incontinence of urine, then don't subject him to any investigation or for surgery starting on the treatment. Alzheimer's disease is slowly but surely it goes, and very difficult. 100 kilometers speed train upon them. 20 kilometers you can make them do by drugs. But nowadays, the monoclonal antibodies are being tried and they say that it is very useful. But the utility of it, we have to see proof. It is there in US.
I have a patient who, the wife comes and tells me this. My husband forgets water, if I ask him to get some Medaka and he forgets every time. So is it
no, that's why if it is going to be every time it's happening, then it is significant. Suppose once in a while you just say you have 2 or 4 things, then it is difficult. Attention span is the one that's very important. If I am thinking something and you come and give me an instruction, I will definitely forget. That's why we always call absent-minded professors. Professors who come home and then they just don't do anything. But if they take the tiffin and then say I have not taken the tiffin, watch out, that's one of the earliest. The latest train is just he looks into the mirror and then sees it and then say he is not recognizing his own face. We call it mirror sign. If a mirror sign comes, that means he has got into stage 3 to 4.
Oh, I think
pills.
Alzheimer, 3 to 4 neuroscience.
A lot of my patients forget whether they're taking the pills. Very often they say. So,
It happens for all doctors and lawyers too. So best is to just leave it to your best friend, preferably wife or other people, to give you the drug so that you don't work. I mean, it depends on where you are working and what. If you are alone, and I always tell people with epilepsy, please ask your mother or father to give the drug for 2 reasons. Number 1, you ask them, the moment you ask them, I am psychologically defeated. A, I am reminded of my disease. B, you are reminding me that I am definitely having an incoordination of memory system not doing well. And hence, I always say, then the anger comes. So, epilepsy patients, you should take the relatives to do it. Now, suppose for example, I have this tendency. Best thing is to write. Because when you write, when you listen, 30%. When you write, 60%. When you really describe it and then do it yourself, it is 90% memory. Operates very well in your mind.
Taking coconut oil.
Coconut oil, the villages, what they have done is excellent. It should be made fresh and then give it to them. Not hold it to the freezer or something, then it loses its potency. Efficacy part of it is good. It is not curable. It is only, we can call it as a progression of the disease is lowered, but cannot be. Our Prime Minister and the former Prime Minister, and both of them have reached the stage 4 stage.
what are the hereditary neurology disorders? Hereditary.
Hereditary neurology, starting from the peripheral neuropathy, we have got hereditary peripheral neuropathies. One hereditary, if the person has a memory disturbance and dementia occurring in the 30th year itself, watch out, you must immediately go think of a hereditary dementias. That is a very one. You have got a genuine one. And hereditary sensory neuropathies are got. You have got a hereditary epilepsy also hereditary. Migraine, hereditary migraine, more than that, I think it is the hemiplegic migraine runs in families. Ultimately, everything is the gene. Parkinsonism, once again, if it occurs before the age of 40, watch out. You must look for a familial Parkinson's. Anybody getting 60 plus, ignore it. It is only an occurrence in the late age. But the point is, it occurs in families. So, family, just because it is there, you can't say it is genetically a Parkinson. There is a subtle distinction between increased occurrence of Parkinson's in a family than a patient who has got definitely a genetic Parkinson's. You must be careful. You must do for immediately testing and then look for it. Now we have got excellent setups.
Speech disorder. What is the difference between Broca's area affected or Wernicke's area affected?
No, once again, Broca's means he will have the speech, contemporary, he can just go. Absence of the speech. Whereas if it is going to be Wernicke's aphasia, then he has got a, what we can call it as a verbal diarrhea, meaning nothing. No
Sir,
problem.
one more
I
question.
think 2 hours, 3 hours class.
I got one because I used to say,
How long we can
Brahma Muhurta is a period during which whatever action you do, it will be a success. Is there any studies conducted in the
Not my line. But one thing, if you do it in the Brahma Muhurtam, it's a very good, your brain is very active. But the problem is, after 7, you are supposed to go and rest. In our setup, it's not there. You after 7 only you start working. Brahma Muhurta, efficiency goes totally. But you must work in Brahma Muhurtam. Goes and has his food at 10 a.m. and then goes to sleep between 10, 11 to 2. But we are not doing that. We are doing the other way around. You get up at 3:30 and then lose your sleep and then start working during the day. That will result in insomnia either with the dust or with We always call it DUS. DUS means disorders of excessive sleep, or disorders of initiation and maintenance dim sleep. So, other but nobody. But one thing which I personally did was to have the Om word. If you use it, then the mathematics. Even when you keep silence, that's a recent research. By silence by all of us by 20 minutes, immediately especially the neural connections are more in the frontal lobe and temporal lobe. Noise really takes you back. Especially silence gives you very good memory. So, answering to your point, the answer is I don't know. I have not seen anybody doing that. Including, I was looking out because I gave a talk on our ancient people, our Vedas, and as well as the DNA. That I gave it in the Tattva, and I've written the talk also in the Tattva. But I have not seen anybody who has done good work. But in India, most of the older works are not following the international acceptance. That does not mean that it is not there. We are not able to study it still. I would rather put it that way. We are not studying like what the Westerners believe is the science.
Insomnia is a neurological disease or psychological?
Insomnia is definitely a neurological problem. Everything is a neurological problem. It has got a basis of the mind. Mind can really change the brain, but the brain cannot act on the mind. And the mind, sorry.
Any tips to prevent or postpone dementia, sir?
Yeah, absolutely, sir. This is something which I always felt. Remember the famous golden dictums. Before 20, abuse, misused your brain and body. Brain, mind and body. 20 to 40, do not abuse your mind, brain and body. 40 to 60, do not misuse your mind, brain and body. After 60, do not disuse your mind, brain and body. Take to reading habits. All these calculations on mathematics, people who come now, you can start doing that. And then third most important point is it. Make them learn something new than what they have already known. There's another method by that. And the fourth method is by writing. Especially when you start writing, your memory is still operated. Never make the old people inside the hall, inside the room, and then be done with it. Bring them close into the heart. Because, especially in the hall, they should sit, and the moment you come home, I'm meaning the sense, sons and daughters, they should sit with them whether they like it or not. Talk with them. Don't make them low. If they are left alone, the chances of the dementia, a predisposed person. As you rightly call, dementia means D is degenerative problem, E is energy problems, M is medical and scientific problem, E is electrolyte problems, N of course is. All this dementia itself is coming on. Give them a nice work and then start learning. And the ideal thing, I would rather say they can play with, instead of listening to some trash at a distance. I think they should start reading. Reading habit, reading maketh a ready man. Writing maketh a complete man. If both of them are combined, then you don't get dementia early. But still, it is only due to our already system wired.
Any of these herbs like Vellari is really good.
Yeah, Vellari, once again, it's proved very useful.
Oh, the scientific evidence.
Once again, double blind crossover study nobody has done. Then nowadays, the study is being taken up. But as I told you, all the 3 M's are needed in India. Motivation is there in every one of us. Manpower is absent. You can't make the work in the morning from 8 to 2 in a hospital workup and then ask him to do a research work. Unless he sacrifices the whole day. Private practice and marriage are the 2 extinguishers of science. That's what really the greatest man who invented the speech mechanism said at that time itself. So you must do that.
Facial palsy.
Sorry?
What can TV for a long term?
Facial palsy.
Facial nerve palsy. So facial nerve palsy, once again, it's a very common occurrence. Commonest is unless proved otherwise diabetes. 2. When you are going to sit in the AC room, the AC blast should not come on then face. It contains full of viral particles. If you are a susceptible person, once again, what I mean susceptible is when you start looking into your immunological system, it goes by the 3 rules which every one of us knows. Quantity of the mechanism, and then the severity, and then finally I am susceptibility. IgG, IgM, IgD, we don't do in every patient, but because it costs money. So if a person gets a 7th nerve palsy, match out 2 things. One is exclude diabetes, second sarcoidosis, third of course is you will malignancy. 4, you can also get it in HIV. Private practice. I am not giving the differential diagnosis of what is given in the book, but the practice point is if it starts and then please start the treatment early. There are people who say whether the patient, irrespective of that, you can start using the drug, but steroid use, especially if there is a pain. Second, especially patients having 7th nerve palsy, having a tinnitus, having a loss of smell, loss of taste, watch out, he is going to have a problem. Otherwise, if he has no increased tone of the tongue, means voice in the ears, and then taste is retained, then those patients do very well. But the only point is, if it is due to a herpetic part, the facial palsy causes herpes with a component, then it becomes a very difficult attack because he's going to develop post-herpetic neuralgia. But the point is, people don't use gabapentin. This is a very practice point. Use gabapentin along with your regular drug. You can prevent the post-herpetic neuralgia coming in at least 40% of patients. Otherwise, it's difficult.
At the initial level itself.
In the initial level,
Gabapentin.
gabapentin. Dose, I always use the 100 milligram 3 times a day.
The same after you try.
How long, sir?
I always use it up to 6 weeks.
Steroid
That is the time when you look at it. 3, 7, 11, 13. The dash itself will describe this totally over about 2 weeks time. And then the scabs, all of them coming out and then leaving behind it. There are teeth, of course, there are people have described now post-herpetic neuralgia consisting of 3 types of sensory disturbance depending on what drug that you use, but that becomes more systemic and arithmetic.
What is the ideal drug for post-herpetic neuralgia?
Ideal drug for post-herpetic neuralgia still is the gabapentin plus initially. And then if the pain comes in, pregabalin will be very useful one for a shot. But whenever you use pregabalin for more than 3 months, please check the eye pressure for either closed glaucoma or open glaucoma. Second, look for any stones in the abdomen. Though they say it is not, but still you should do it. Put it in your prescription itself. Please check your eye pressure and then the stone.
So is it helpful in trigeminal?
Sorry?
Trigeminal.
Trigeminal neuralgia, just once again, very clinical point. If it starts with the trigeminal neuralgia from the eye into the angle, immediately you don't have to worry that much. Because trigeminal neuralgia can usually stop its V1 or V2 or V3. If it gets in all the 3, a report for a sexual history. If it occurs in the beginning itself, you don't get a trigeminal neuralgia in all the 3 areas. Second, if you get a trigeminal neuralgia vertically, 100% it is syphilis. Syphilis, vertical. You get only horizontal. And third, beautifully you start treatment in the beginning itself for 3 weeks. Trigeminal neuralgia. And the second point is when the trigeminal neuralgia pain is post-herpetic terminal, if it persists for longer time, doesn't go with any one of the standard therapy, then you may have to go for any immediate base of the skull and as well as CT brain, whether the arteries are pressing upon the fifth nerve. Fifth cranial nerve is the only cranial nerve which has got 3 holes and 3 divisions go through this. All the other neural cranial nerves go through only one area. Whereas this one has got 3 foramina God has given us. And hence you have to be very careful which one is pressing what.
So when alcoholic ablation done?
Yeah, alcoholic ablation is the first step. The 100% relief is not there. Then they do the definitely surgery in the base of the skull surgery. Then they get.
Yes, it is that.
Is it?
Treatment for upper motor neuron and the lower motor neuron lesion in facial palsy is the same or different?
In facial palsy. Facial palsy, upper motor neuron and lower motor neuron when you take it. See, depends on which condition it is accompanied. If you get only a simple lower motor neuron type, upper motor neuron type, look for the stroke. Because one of the means is either you get full stroke. We call it by 2 methods. Number 1, full hemiplegia, or we can call it as a small vessel disease or a large vessel disease. If it is a large vessel disease, it occurs like a pulse, that is face, arm, leg and time. Whereas if it is a small vessel disease, depending on which portion is involved, for example, if it is only 7th nerve, you treat him as a definitely as a stroke patient. Something like getting a visual disturbance suddenly. If you get that, then it may be an early stroke. It can precede the stroke immediately within a matter of 3 months. So the incidence of stroke following a transient neurological symptom, that fellow requires an immediate admission. So I would rather admit a transient ischemic fellow into the hospital rather than the squad person, because transient ischemic fellow will get the stroke within 3 to 7 days. So you should not miss him.
Good enough. Yes.
Thank you.
So I think we can give a quick hand to. So on behalf of Indian Medical Practitioners Association, I request Madam to hand over a memento to our speaker and
I think we have listened to something which is like an ocean. We are trying to gulp it in one gulp.
But
That
neurology-
is not possible.
so neurology has always been difficult in undergraduate level. No? I always shunned neurology. Yeah. So we also have pleasure in handing over honorary the speaker for doing a lot of free medical service and all that. So
Thank you, Aries. And we are giving on behalf of our association a token of credit.
Thank you, ma'am. I'm indeed wordless and speechless for the kindness and courtesy, and especially my chief was the president is the first one. He gave the life, because in life there are only 2 things. I always call it. One is the faith, another is the truth. Both of them were with Professor Rathnamani Subramaniam. I always call it truth without faith, you are blind. Faith without truth, you are deaf. Faith and truth are united by unselfish love. If there is no unselfish love, you will not be faithful, you will not be truthful, and you will not be truthful to your family, everybody. I think the truth and faith I have seen here, I think you are going to have a good peace of mind from this association, particularly from my boss. It's the greatest. I felt I'm really humbled today when I saw the photograph of Professor Rathnamani Subramaniam sir. See, exactly, I was an inpatient when I was 9 years old. Now this is 66 years old later, I'm sitting here. I'm remembering till my death. Thank you.